Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the kind of my notes from the last Shockwave seminar that I went to. This is one I go to. I think this has been number 3 times that I've been this, and I want to kind of go over some of the high points, some of the key phrases, kind of showing you some of the ways that I've used AI, kind of how Shockwave has helped. All this can be found in my wiki. If you go to podiatrypracticemastery.com/WIKI, you can get access to it. It's a Notion page. If you're not familiar with Notion, this is kind of a way I put things together and I store ideas. Okay, so let's kind of go into this. Here is an outline, and as I get new ideas, I put it here. And if you click any of these links here, it will go to the section within the seminar slides. Also, if you want access to the actual slides from the conference, I put those all into Google Drive. So you can click on that, and then you can look at all the Shockwave resources right here. Some of my favorite lecturers were Paul Hobro. I have most of his. He talks a lot about business and marketing and the way to include that. Also, Chris Milkey is very, very good. And so I put some of the ones that I liked the best in that for you to review if you would like. I also put a calculator up here. If you haven't seen this calculator, this is a calculator that can help you calculate the effectiveness and profitability of Shockwave in your practice. I put this together because there's a lot of doctors that had questions about this. So if you click the Shockwave button right here, it should bring you down to this second page, which is on Shockwave. And in this, you can download the sheet. And I put in the price of the technology, the discount price, how many years it'll last you, the number of new patients you're treating with the packages, how many weeks you're working, the average treatment payment, number of treatments per patient, the repair costs, any disposables. And I did this because I have this also for Swift and for other things that have a disposable that's included. Patients that get any advanced treatments like amnio and things like that. Those are the other things. Okay. And then it'll kind of pull out what the price is. It'll pull out here the yearly return on investment. And then it'll pull out here the break-even number of treatments. So the break-even is you have to do 26 treatments to kind of break even with this. And that can be pretty quick if there's 3 treatments or 6 treatments per patient. The cost per treatment is like the expense that it actually costs. And the yearly cost is $6,500 if you're going to amortize this over 10 years with the other costs and things like that. The revenue, the neat thing is when you look at it, if you're doing 5 new patients with only 3 treatments, you're going to produce 175,000. But if you switch that from 3 treatments to 6 treatments, it's automatically going to increase the profits quite substantially. And then if you start doing add-ons such as amnio and orthotics, it can really go up to a high amount for your practice. Okay. Okay, let's go back here to look. Here are a couple of the reps that were there. There was some Orthobiologic companies. I put links there. All the Curomedics resources are right here. You can link to those. I'm not going to go into detail with that. Okay, one of my colleagues asked about treating tarsal tunnel. I don't use it a lot on tarsal tunnel. I don't think I see a lot of tarsal tunnel in my practice, but the key is to use focused Shockwave with very low energy, 0.01 to 0.05, because you're working on a nerve. Similarly, when you're doing neuropathy and when you're doing neuroma, I do not do any neuropathy. I tried it a few times, didn't see much improvement. And then neuroma, I do, and on neuromas, occasionally. Some of the key phrases I found that were important in this course were it speeds up the healing. Nothing else has such good evidence. It stimulates exosomes. I don't think patients really know what exosomes are, but focused Shockwave stimulates stem cells. I think all patients know about stem cells. So I think those are some important key phrases. They did some comparison. Certainly they're going to try to downplay some of the competitors, but the Shockwave Curomedics lasts about 2 million pulses, and they say that Softwave, which is one of the competitors, only has a 500,000. Now we have both Shockwave and Softwave we're getting used to. We have Shockwave for many years, focused and radial, and then we also have Softwave as well that we're trying out. I'll let you guys know as we go on and use that more. Also, a couple of ideas would be using post or pre-surgery. So, for example, I had a patient that had a Haglund's that I repaired, but I did do Shockwave prior. She wasn't able to tolerate the Shockwave, or just the pain was too bad, and we ended up transitioning her to surgery. And she just had an abundant amount of blood flow to the area during the surgery. I could see the blood vessels in there, and she had, because I'd done bilaterally repair with a Arthrex speed bridge. And what she said is that like the side that we did Shockwave before just responded so much quicker. Okay. So potentially considering using it on Haglund's repairs. You could even, I guess, consider it on bunion repairs or other types of things. You have to have a big enough surface area though for the incision, maybe like a peroneal tendon repair, doing it before that, doing it for posterior tib repair. I'm not sure about a hammer toe. I don't know if the hammer toe is too small, but, and then also if there's a lot of swelling afterwards, you could do it after, just the same way you would use it after like an ankle sprain. I'm a big advocate, and they recommended once again using ultrasound to show inflammation around the tendon, using the flow setting. So we use ultrasound all the time, and I find ultrasound is the number one reason why I do so much Shockwave, because I can show the thickness of the plantar fascia, I can show the thickness of the Achilles, I can show the effusion around the tissue, and that is what helps people to understand the need. And I can show the contralateral side, and that's why I can do so much of this. It can also help increase flexibility, especially if there's areas of thickness, if there's areas of scar tissue. Consider adding sclerosing injection. I don't do sclerosing. I know some of the doctors that were talking at the conference did use it for sclerosing. And then consider adding with laser. Now we do have a number of lasers here. I use laser. I believe it works well for warts, but it hurts. I've used it some for scar to help kind of orient the skin. I don't use it much for nails. I really don't have the best confidence in it, and I don't use it for pain, even though I do have a pain laser. The main reason for me is I don't have time to do it if it's only doing the pain laser, meaning I think pain laser can be $60 to $80 per treatment. That's just not the type of practice that I have. I could see adding it on to a Shockwave treatment as an add-on or an adjunct, or even just including it in the package. That would make more sense. So instead of charging 200 to 250, you would go up to 300 using the laser as an add-on. I think that would make sense. There's a couple of new websites for info about Shockwave and about EMTT. Talked about using eccentrics, talked about for insertional on flat ground versus, and I always tell patients that they don't want to go, when they have insertional Achilles tendonitis, they want to go below the surface. Like you don't want to have them go on a step to go down. That can really aggravate things. Go low energy. It doesn't have to be too painful. I think if there was one mistake that I've made in the past is I think I went a little too heavy-handed, a little too hard, and that caused pain for patients. So usually for tendon, 2.25 for focused or under, and for bone, 0.25 or over to get to the bone penetration. EMTT, we don't have that in our practice. I was under the understanding it was more for arthritic pain. Most people use it as an adjunct. They'll do it either before or after the other treatments. Some doctors do it on a standalone, like $80 per treatment. It's twice a week for 3 weeks. It's done unattended. That's the thing I like about it, is it can be done unattended. I talked about using for fibroma, seeing best results at 6 months. I'm telling patients that more and more. The results take a long time. Using Shockwave for hypertrophic scars, for treatment only do charge and do what is needed. Okay. Yeah, so this is a kind of a conversation about what you charge for. So I know there are some philosophies saying, okay, I'm going to have them charge so much for radial, so much for focused, and then so much for EMTT, and then so much for laser. I like the mindset is I'll kind of recommend what's needed to get you better, and it'll just be one price, because patients don't know the difference. So they don't know the difference between radial and focused and laser. They just know that they want to get better. So I believe in kind of just having one package pricing. Here's a couple newer tips that they have that are a little bit softer, and they can be used for Shockwave. These are ones we do not have in our kit, but here are some of the more common ones. the most this D15 is one of the most in our R15, I think it's called. These are the most common ones that we use in our practice, like the gold tip or the cobalt tip. Actually, the C15, we use the cobalt tip if it doesn't need to be as intense. And then occasionally on bigger surface areas, I'm using these. Nowadays with Softwave, it's a bigger surface area, so I can get a bigger surface area with some of these other Shockwave things. So I'm going to go over some of the main important, in my opinion, what I look at, what I got out of it. This was a lecture by Chris Milkey. He's a podiatrist. He does great work in terms of marketing. I like one of his phrases. He says, "And is better than or." Um, uh, do I do this or this? Or should I do Shockwave or Orthotics? Whereas I think and is a better option. Should I do, we are going to do Shockwave and Orthotics and amnio versus or. I think patients want to do this or that, and I think we have to be confident enough to do that. His best conversion tactic, and I would agree with him, is building trust and connecting with the patient and having them trust you as a doctor, and then you can transfer that confidence. And you need to be able to do that when you're talking about price of things. I always joke, I know I have some colleagues that do many more orthotics than I do, but they're in an area where orthotics are covered by insurance, and it's easy to give away orthotics, in my opinion. Um, even though he does a lot more than me, but even if they weren't covered, I think he would do a lot more than me. But if you lack confidence, they'll notice it. Okay. His best marketing tactic is to position yourself in what you want to do. And I've talked about this a lot. So if you do Shockwave, what we tend to position ourselves on is plantar fasciitis and Achilles tendonitis and other types of itises. And so we don't really market as much Shockwave because patients don't really know what it is, but we're having patients now come back for it because it's worked so well. So when I talk about it, I go over it kind of speeds up things. Okay, you speeds up the healing by 50%, and it's about 82 to 85% effective. And I would position Shockwave as kind of one of the things that you focus on. I'm a big advocate of doing the following: reducing low value patients, so not having the level 2 visits really come back at all, not having patients that don't want to take your advice come back at all, don't have them, or have them come back only in a long time in between. And then the ones that are opting for your treatments, have them come back more frequently. They used an example of Shockwave was like a mouse. So it has a big body and a long tail. That's how Shockwave is. So you do 3 to 6 sessions, so a lot of visits right away, and then a long tail afterwards to see the improvement. Okay. Um, this is another thing that he recommended, is that the 95/5, that only 5% will need to know you when they're listening to the ad, but you should be focusing, you want to be top of mind to people that are within 5 to 10 miles. So if we're a local clinic, we want to be, if we're going to do like Google AdWords within 5 to 10 miles. Certainly other patients can come from further away, but most patients come from real close. You want to really dominate this local. You want to have this halo effect. So if you're going to focus on marketing a local newspaper with a really small vicinity, Google AdWords with a really small vicinity, these are all going to be important for you. He talked a little bit about power moves and having an origin story, and I think this is something that's important when on your website, to kind of go through your story of how you got into podiatry. And this can be done pretty easy. The easiest way, in my opinion, is to kind of to dictate this into your phone and then send it over to a chat GPT to kind of have an outline that you can put on a web page, kind of like my origin story or why I got into podiatry. I think that's something important to share, kind of why you got into practice, why you like treating patients. One of his best power moves was doing a weekly email, and I'm a big advocate of this. Send out what you want to see. Okay. And also give your best value. I've heard this from Alex Hamosi one time. He says, like, if you feel a little like, oh my, I'm giving away the farm by giving this out, that's what you should be giving. And that's what I try to do within Podiatry Practice Mastery. I try to give away everything because I think the right people will come and want to work with me even more. Okay. Same thing in our practice. We try to give out everything. I know in the past I've had people critique me saying, "Oh, Don, I can't believe you explain how you do ingrown toenails. I can't believe how you explain how you do plantar fasciitis." But the more we explain, I think the more it draws patients to us. So when you're sending out your weekly email, what I've done is I have 12 areas that I want to focus on, and these are my high revenue producing things. So 1 month is going to be orthotics, one's going to be AFO, one's going to be Shockwave, right? One's going to be other types of in-office procedures. So all these, and so each month I talk about those for the 4 weeks of the newsletter. Every week I'm going to be talking about those things in that newsletter. So it's pretty easy. Now, a newsletter is usually 80% entertainment and 20% education. So I usually do one article about about the condition or what I'm talking about. And then I also do most of it entertaining. Usually it's a story about my family. If you want to see ours, you can go to centralmasspodiatry.com/blog, and you can see there's a link on there for the newsletter. You can kind of read through how I do those. I use a virtual assistant. I design them actually in Notion like this, and that's how I do it. But including videos and including written content, um, and then adding videos with the transcript, meaning you do a video and then it transcribes it and puts the wording underneath the video. CRM, have a place to put all your emails. That's a given. We use Kajabi for that. We talked about writing a book. I think writing a book is a good thing, whether it be a written book or a PDF book. And then be fast, be convenient, be different. Google AdWords. Talk about the treatment. So talk about Shockwave. Talk about it as an alternate to surgery. There's no risks, no shot, no downtime. Talking about the treatment protocol, the expected outcome. Share like stories. This is something I'm not very good at, or I haven't been up to this point. I think I'm going to improve. But when you're seeing someone, for example, with that insertional Achilles tendonitis that's resolved with Shockwave, I've had like 10 other patients that have resolved with this. Yes, it takes a long time, but it gets better. So I can use that to build credibility. And then also tell them what would happen if they didn't do this, like the fear of, okay, we would have to do possibly a Haglund's repair or do a surgery on this, and I think we can avoid that. What Milky ended with, he talked about his best three. So one would be a dynamic demonstration, and the way Milky does it is he does it with an MRI. My dynamic demonstration is an ultrasound. So if you don't have ultrasound, you might want to consider getting MRIs in everyone, and that'll kind of help them nudge them towards doing the Shockwave. Marketing was the weekly email, and then protocol was convenience and speed, meaning when you see patients, what I tend to do is I do Shockwave second visit. So first visit, they're getting the night splint, other types of things like that, meloxicam. Second visit, I'm doing the ultrasound, which is my dynamic demonstration. And then what I'm going to do is I'm going to set up Shockwave that day and actually do Shockwave that day and set up the other ones. So I use some AI for a couple of these things. So I took a lot of these things that Milky talked about, and I put them into an activity list. So what you would need to do to work on all these things, some strategies in 15 minutes a day. So I put this in AI, make me an activity list of how I can do all these things in 15 minutes a day. So I put this in here if you think that would help you for your practice. I'm a big advocate when you learn something, a lot of times we have a hard time like applying it to our practice. So that's why I like to do that. And then I applied it specifically here. You can see to plantar fasciitis. So if you go into this list right here, this is I use this with AI as well. I talked about Shockwave therapy for plantar fasciitis, did with AI. Specifically to it, I answered these questions. What is Shockwave? Why isn't it an alternative to surgery? No risks, treatment protocol, expected outcome, share like story. What happens if you don't? The investment. So everything that was talked about in his lecture, I put this in and did it according to Shockwave. So you can do this for any condition. It gives you kind of a little written explanation of how to do that. My second favorite person that was there was Paul Holbrow. He is from across the way in England. And he talked a little bit about a few things I think that we have questions about, like arthritis. It helps with bone marrow edema. It doesn't really help to restore the cartilage, but it helps with the swelling underneath the bone. You have to get up to 2.25 on the focused to do that. So if you're doing it for arthritis, I might do it for, let's say, midfoot arthritis or first MBJ arthritis. You have to get up to 0.25, and that's sometimes the challenge if it's a painful joint. For example, I'm doing a patient right now with first MPJ with like hallux limitus, and it's painful, and I can't get up to 0.25, so I'm not sure it's going to work because I don't think it's going to help with the bone marrow edema. This is something he said, if you are not confident, you're not going to be able to sell it. And I'm a big advocate in the beginning, both with ultrasound and Shockwave. We used to almost give it away or do it for very cheap, let's say for the first month while you're learning it, because that way you can develop confidence that it really works. Okay. So this is something that's important. And also another thing he talked about, like if I see a great movie, I'm going to want to share with everyone. And that's what it should be. If it's like really working, you're going to want to share with everyone, and everyone's going to share with everyone else. It helps people. And if it does, you have to share it. So offer only a few choices. And I think that's a challenge where we give people too many options. Paul has a kind of an elegant way in his slides, if you look at his slides, but you offer them, okay, you can do what insurance covers. Okay. You can do kind of regenerative, which would be Shockwave, or you can do like the whole kit and caboodle, which would be Shockwave and then amnio. Okay, kind of giving those three options for patients. And you want to educate them. And he gave this example: if the patient asks you, what do you think? It means that you haven't educated them enough. You might need to go over again. What I tend to do is when patients come in for the first visit, I give them a video on my blog that explains the treatment for plantar fasciitis, including Shockwave, and then I reinforce that when they come in the next time, so I can explain it. I tend to tell them the same thing. It speeds up the healing process faster than you can do on your own. Paul kind of broke things into different sections. I think one of them we talked about before is developing rapport with the patient, kind of talk to them, talk about them, learn about their family, tell them what's going on, kind of what brings you in, why are you struggling, and tell them what you think it is. Like, this, we can tell what it is. This sounds like Achilles tendonitis or plantar fasciitis. And he has this simple 3-question process, and I put these into my patient presentations. But what are some things you can't do as a result of your pain? What are your goals when you're pain free? And what will it mean if you achieve these goals? If they don't tell you everything will be Christmas, then don't offer it. Meaning, if you really can't help them, like for example, some patients, it's not really bothering them. So you're not going to offer Shockwave because it's not really bothering them that much. The key is kind of focusing on only those that you can really help. The ones that aren't really bothering them, they're going to go away. Not really, I don't really see them back unless they're really ready to change or they really think they need help. And sometimes they need time to think, and that's where I tend to present at the first visit, and I see them at the second visit. What Paul does is he explains it, and then he does some therapy or an evaluation and gives them time to think about it. So and he demonstrates kind of why it hurts, why they need treatment. He talks about other patients that he's seen. He talks about statistics. I use the same statistic. It's about 82% effective, and it speeds up the healing about 50%. And the popularity, we do a lot of this. You're like number, 5 or 6 today that I've done with this. And he talks about this thing like gypsy warnings. And this is something that he said, kind of a wording. Like sometimes you have to make a health decision. Sometimes you have to make a health decision, and sometimes it's about economics. So you should focus on your health over the economics when it talks about pricing. He also talked about having different levels. This is what I talked about, the 3 options. We has bronze, silver, gold. I don't really do it exactly this way, but you can do traditional insurance, regenerative treatments, or like the whole kit and caboodle with the amnio and the orthotics, and then cut down the number of choices and talk about the expected time. I find that patients want to know how long it takes. I say we'll do the 3 to 6 sessions. Then I see you back 6 weeks later, and then I'll see you 6 weeks later again, and it takes a while. Okay. A couple of other things that Paul talked about. With Shockwave, it reduces pain, reduces tendon stiffness, helps recovery. Misconceptions that patients say, I don't have time, it's too painful, it's only for chronic injuries. Actually, these are things that docs say, I don't have time. Well, if you don't have time, you have to make time for this. And I would prefer seeing this all day long than anything else. It's too painful. The pain should only be 4 to 5. This is one of the errors I made in the beginning, is I think I was going too heavy handed. Some people I had one almost like passed out on it. I asked AI, you can see my script here. I said, please give me a script for plantar fasciitis and Shockwave. So it talks about this whole script and description and everything else and putting it in. You can do the same thing, but you can do this for Achilles tendonitis or anything else in your AI if you want. Okay. That's how I do that. Other people think it's only for chronic injuries. I do it actually first line. I don't do it second line or third line. Some people think it's only for tendons. It's not. It can be used for a lot of other things. And some people say it's for last resort, and that's not true. I do it for, once again, first line. My main phrase I say, it stimulates healing, differentiates stem cells, works on bone, muscle, and tendons. These are some examples that he used. You guys can read this later if you want. There's a couple of other things at the course. They talked about Regen Med. This is where patients can sign up, and it's creating research, and that can be used to sell to other people. There was Amal Saxena was there. He talked about some things as well. I liked this lecture, and you'll see within the lectures, you can see this about from the dynamic athlete. He has some neat ideas of like how EMTT works, kind of having things confused with an injured cell and then realigned in a good cell. He talks about focused. If you feel the sensation, it's working. It passes the normal cells and helps the injured cells. It increases cell proliferation, blood flow, and things like that. So he uses kind of the same thing as I do. The reason to do amnio is if you've had chronic pain over 3 months, that's not progressing. So if the pain has been over 3, or you can even say over 6 months, that's when I would do shockwave and amnio. Okay. Part of it would be the ultrasound as well, but if someone's had it for a longer period of time, it can take a lot longer, and I find that that helps. Okay. He has a lot of slides or a lot of questions that he puts. If you look at his slide deck, it has this, but a few questions to ask, and this is to kind of like people to feel the pain. What do you have? Why you have it? What's already been done? What type of athlete are you? What are you trying to be able to do? I think this is a key. Like, do you want to go to Disney in a month or two? Or do you want to, what's your goal? What odds can I give them for it working? And what does this make sense over other options? And I think one of the things that I'm not so good about is, what is their goal? Like, what are they wanting to do? Do they want to just play with their grandkids? They can't get out, they want to walk, and things like that. So I think we need to kind of clarify. I need to clarify that even more. Also talked a lot about treatments won't be as successful if there's not a buy-in. So you need to kind of all go in the same direction. So another kind of, this is a good quote I liked. So when you do shockwave, it's going to feel a little bit different. The same way when someone heals after surgery or after a fracture. And he had this quote. He says, it's kind of like matching paint in the wall. It takes time to look the same color. And most assess it over 6 to 12 weeks. They don't really see much improvement, but it might take another 3 months or so for everything to remodel. So I liked that analogy. And then this is another kind of quote that he recommended. If you're at 80% capacity, you need to increase your prices. So and he recommended, decide to increase your price, send out an email, say, our prices are going up by 15%. You're going to be unaffected for the next 6 months. You can have the same price for the next time, and you can buy as many treatments as you want. So this is kind of a neat way. If you're kind of really at capacity and you don't have any more room, this is a good problem to have, but then you have to increase prices because it's very fluid. And then there are some Q&A questions. When do you keep them off of activity? Because one of the main benefits to shockwave is you can be active. So if the pain is 4 out of 10, you can keep active while doing shockwave. If you're limping or pain with swelling, you can't run. You should be on like an anti-gravity treadmill. Okay. For arthritis, he recommends 6 treatments every week with a 3-month follow-up, and then repeat that every 3 to 6 months. One failed to progress, you have to determine that after about 3 months. So if after 6 weeks, if there's an improvement of 25 to 30%, if no improvement after 6 weeks, then you have to wait another 3 months. If 75% or better, see how they're doing in another 3 months. And if not responding at all, then you don't repeat. You need to change, because sometimes there are some non-responders. And then someone asked about, is there a need for maintenance? And I think there might be a place for this, for example, for athletes, if they know they're going to get injured at the beginning of every season, if they feel better, if they're not better after the change, you're going to change the treatments. So those are the ideas from the Shockwave course. If you want to, you can look at the notes. There are a lot of links to other pages. There are links to some of the lecture slides. If you couldn't go there, there's my calculator, everything else there. Let me know what you think. Okay. Okay. Thank you.